So I'm going to talk about orthostatic intolerance in the setting of Chiari malformation. Do you want me to wear the mic? Yeah. Okay. Okay.
And if you could, I'll adjust the location of that. You can just put that in the pocket or on your belt clip so it's comfortable. Okay. And that's the best place here. Close to the voice box.
Okay, great. So I'll discuss a couple of medications that are off-label that we use for orthostatic intolerance, but the overall guide of what I want to cover today is to start off with a case presentation that may be familiar to many of you, but looking at orthostatic intolerance as an early feature. Okay, is that better? So looking at a case that shows orthostatic intolerance as an early feature of Chiari malformation. And then for those who are not immersed in this literature, I want to give an overview of orthostatic intolerance, looking at recognition of the problem, some of the pathophysiology, and then how we treat it. That will be necessarily brief, but I've got some references at the end that people can look at later. Then I want to look at some of the clinical observations that have been made. One about the ability for syncope and POTS symptoms to improve after surgical decompression of the Chiari malformation. We've had a couple of patients who've had post-decompression orthostatic intolerance that's unrelated to the surgery. It's not a problem from the surgery, but it can mimic and look as if the surgery has gone wrong, but it really is a separate problem that needs its own treatment. And then I want to end with some observations we've been making lately on improvement in POTS and chronic fatigue syndrome in a series of 3 patients following surgical decompression of their cervical spine stenosis from bulging discs. So that's the overview. We know from older literature, dating back at least to the 1980s, that syncope can be a presenting symptom of Chiari malformation. Less commonly appreciated is that these patients can have orthostatic intolerance without recurrent syncope. So let me show you a 15-year-old who came to see us a few years ago. She'd been healthy and active doing drama and music work until she developed mono at age 12. She got a little bit better after the mono, but never back to her pre-illness baseline. When I saw her at 15, she was tired all the time. The fatigue and other symptoms would get worse after exceeding her limits on activity. And it would get worse with shopping. And as we often say to our residents, if a teenager is tired when they're shopping and unable to go to the mall, they have an organic problem until proven otherwise. She also got more symptomatic playing a wind instrument. By this time, she was lightheaded daily, especially in a hot environment like a shower or standing in choir. Her dad was the minister at the church. She had a number of features of chronic fatigue syndrome, like unrefreshing sleep, this post-exertional worsening, arthralgias, and even though she'd been a bright student, she was starting to have trouble with math problems. Headaches at this point were only every couple of days. So on her examination, she had very velvety skin, a high-arched palate, a hyperextensible upper eyelid that you can see in the top. She had piezogenic papules, which was an outpouching of fat pads around the ankle when she had pressure on them, shown on the lower picture. Blue sclera, and she had a very high Beighton score, all consistent with hypermobile Ehlers-Danlos syndrome. Her neuro exam at this time was normal. You're not going to believe me when I show you her slide later, but it really was. We investigated her orthostatic symptoms with a standing test. We usually have people supine for 5 minutes, and then we stand them leaning against the wall for 10 minutes. And she had a marked increase in heart rate from about the 60s up to well above 100 just with standing, and it reproduced her symptoms of fatigue, lightheadedness, nausea, and she also had a sort of a hot flash. Her 55-beat increase in heart rate was well above the 40-beat increment needed to diagnose POTS at her age. So we treated her with salt and fluids and Florinef and Midodrine, and she was able to get to school more regularly, so this was a pretty good outcome this soon afterwards. Then she got 2 consecutive viral upper respiratory illnesses at 8 months, and unexpectedly had this marked increase in fatigue, sleep disruption, and headaches. And she got to the point where she was unable to attend school again. So we had her come back down to the clinic, and now her exam was noticeably different. She had rotatory nystagmus, a diminished gag reflex, brisk reflexes, and 2 beats of clonus at the ankles. And as I said, she was normal beforehand. Here's what her MRI looked like. And I think there's a bit of distortion from the way the PowerPoint is going, but you can see a retroflexed odontoid. Her cerebellar tonsils are triangulated well below the foramen magnum. There's a bit of a sort of suggestion of basilar impression, and she has some obstructive hydrocephalus. So she was really sick, but the point I make is that she had had this same anatomy for a long time. She must have done something with these respiratory illnesses, perhaps had a bit of a spinal fluid leak to increase the intensity of her symptoms. But again, they were probably related to her neuroanatomy. All right, let's move on to talk about orthostatic intolerance. This is a general term that refers to a group of clinical conditions where symptoms are worse with quiet upright posture and are ameliorated but not abolished by recumbency. And the main physiologic challenge we face when we stand up is that we shift about 500 to 750 mils of our blood volume into the lower half of the body. And this cartoon from Philip Lowe's textbook shows the increase in blood pooling in the leg veins. This is a bit incorrect because a lot of blood also pools in the abdominal circulation with standing. The normal response to that shift in blood is first that you get a bit of a drop in arterial blood pressure. That reduces the amount of stretch in the vessels in the neck where the baroreceptors reside. That leads to an increase in nerve traffic to the cardiovascular nuclei. And the nervous system response that keeps us going and allows us to stand and teach and wait in line and go shopping is a increase in sympathetic nerve activity that leads to about a 10 or 20 beat increase in heart rate, a little bit more forceful contraction. And the biggest part is that you get norepinephrine release from the nerves that leads to vasoconstriction, vascular constriction, which shifts the blood back up to the thorax and the brain. So that's the normal response, and if you do that, you can be upright for quite long periods of time. If that doesn't happen, then you get these symptoms of orthostatic intolerance. And I'll break them down into the 2 main pathophysiologic categories. The ones on the left are thought to be due to reduced blood flow to the brain. So that makes sense for things like lightheadedness, fainting, poor concentration. Also, headaches can be from this. They can get blurring and dimming of the vision. Fatigue is very common in all forms of orthostatic intolerance, as is exercise intolerance at the bottom. Then the other symptoms are thought in large part, not exclusively, to be due to this hyperadrenergic response. That is this huge increase in catecholamine release that's intended to bring blood back up to the heart. So these patients can get short of breath, they get chest pain, palpitations, tremulousness, anxiety increases, they can have a lot of sweating and nausea as well. So these are widespread systemic symptoms. The common forms of orthostatic intolerance, the first 2 I'm going to mention are less common in the young people that we see in pediatrics, or at least less of a problem. Instantaneous orthostatic intolerance is a condition that's very hard to detect unless you have second-to-second blood pressure and heart rate measurements. These are teenagers typically who stand up, they get about a 40 millimeter of mercury drop in their systolic pressure with visual dimming, have to hold on to something, and then this resolves within about 15 seconds. If you've got a regular blood pressure cuff, you're likely going to miss this. But these patients don't need treatment. Just because they get lightheaded when they stand doesn't warrant therapy unless they also have chronic orthostatic symptoms. The next one is orthostatic hypotension, which tends to be seen in people who are older. I used to think that was that meant over 40 when I was 40 years old. Now it's over 60. But these are people who often have other neurologic problems or diabetes, and they get a sustained drop of 20 millimeters of mercury of systolic blood pressure, 10 in diastolic, within just 3 minutes of head-up tilt or standing. So this happens immediately. They often have supine hypertension. So they have a problem when they lie down that their blood pressure is too high, but when they stand up, it drops like a stone without a compensatory heart rate increase in most cases. The more common ones that we see in our Chiari patients and our chronic fatigue syndrome patients as well are shown here. One is the kind that you just saw, postural tachycardia syndrome, where you get more than a 40 beat increase between supine and standing in adolescence. The adult criteria are 30 beats per minute increase, and that's in the first 10 minutes of standing or tilt. Or if you have a heart rate above 120, that counts as POTS. They have to have chronic orthostatic symptoms as well. It's not just the tachycardic response that counts. And you can't have POTS if you also have that orthostatic hypotension in the first 3 minutes. The other form that we'll see, and this was what we originally saw 20 years ago in our chronic fatigue syndrome patients, is called neurally mediated hypotension, synonymous with vasovagal syncope or neurally mediated syncope. But many of the patients have never fainted in day-to-day life, so we chose neurally mediated hypotension as the preferred term. This is a graph of a patient who was a medical student at Hopkins who'd been pre-syncopal in her first couple of years of classes, sitting all day. And here's where she goes to, she's supine, then she goes to a head-up tilt to 70 degrees. Heart rate only goes up 9 beats per minute. But her blood pressure is fine for about 5 minutes. She's lightheaded and pale, and then the bottom falls out. Her blood pressure plummets down to 50 systolic. This is a classic vasovagal or neurally mediated reflex, where you get a drop in heart rate when blood pressure is dropping. And she even had some tonic-clonic movements as she went down, likely related to the reduction in oxygen to the brain at that moment. So that one requires at least a 25 millimeter of mercury drop in systolic blood pressure, usually with chronic symptoms. And you'll sometimes see that the only form of chronic orthostatic intolerance is POTS. That's just incorrect. Both forms of disorder, circulatory disorder, can be associated with chronic daily symptoms. One of the physical findings that we see a lot is dependent acrocyanosis, a term for purple discoloration. And this is a slide showing a girl who had to drop out of college due to her fatigue. Here's her hand after about 5 minutes of standing, and my hand is behind hers for a color contrast. Here, I think you can see that I placed my fingers of one hand against her leg and compressed them, then stepped back, picked up a phone, fiddled with it, tried to focus it in. So 5 to 8 seconds elapsed, and she still had no capillary refill to this area, again sort of emphasizing the degree of circulatory dysfunction in these patients. So the recognition of these problems is usually through the history, and the historical questions that have a very high yield in orthostatic intolerance regardless of the cause. One is, have you ever fainted? How long can you stand still before you feel lightheaded or unwell? And many of the adolescents don't even know, they don't recognize what lightheadedness is. They'll talk about a head rush, and they think everybody has head rushes. Why are we focusing on that? We ask them, how do you feel in the following settings very specifically? How do you do waiting in line? And I had one girl whose dad is a physician who went to a university, and she said, oh, I don't have lightheadedness. Well, how do you get to school? Do you walk? Oh, I don't have enough energy to walk. Do you ride your bike? No, can't do that. Do you take the bus? Yes. How are you when you stand in line for the bus? She said, oh, I can't stand in line for the bus. I sit on the curb. So that was the key, that she had orthostatic intolerance, but again, she wasn't endorsing the key lightheadedness. Standing quietly at receptions, in a chorus or band, at a religious service, those are really situations where these patients have trouble. They have trouble as well in a hot environment, so they will often be found sitting in the shower. They get really lightheaded in a hot tub or a sauna. and they don't tolerate heat like we've been experiencing on the East Coast for the last few days. Another thing to ask them is, how do you do when you're standing still? Do you fidget and move around a lot? Because that uses the leg muscles as a pump to get the blood back up. And many of them, without knowing why, will study in kind of funny positions. They'll recline, they'll sit there with their knees to their chest, and often this has been a source of argument at the dinner table, or they put their feet under them, and some of the girls with this will drive with the left leg either tucked under their bottom or actually up on the dashboard to elevate it and get better blood flow. So you can get a lot from the history of their positions in day-to-day life. To break down the two common forms of orthostatic intolerance, neurally mediated hypotension is the most common cause of recurrent syncope at any age. It's more common in women, in younger people, and in those who start off with a constitutionally low blood pressure. It can occur after an infection. Usually family members are also affected. The routine physical and laboratory tests are usually normal, and so often they've been patted on the head and told, "Aren't you lucky, dear? Your blood pressure's so low you'll never have a stroke," which doesn't really acknowledge the problems they came in with. The hypotension, unlike the slide I showed you of the medical student where she had really early onset of syncope, many of these patients don't get hypotension unless they're up on a tilt test for a long period of time. 29 minutes was the median time to developing hypotension in our early CFS studies. But they're symptomatic from a very early point. And the other thing that's interesting is fatigue is very common after a faint. You can have up to 72 hours of tremulousness and fatigue after an episode of syncope. And our thinking is that recurrent activation of this reflex pathway, even if they don't faint, causes a buildup and a debt of fatigue that lasts more than they can sleep off. This might not be that visible, but it's meant to be a diagram showing this pathophysiologic sequence. You have an upright tilt or standing, you get a reduction in venous return to the heart, a drop in blood pressure, an increase in epinephrine and norepinephrine, and in the setting of an underfilled ventricle, these catecholamines cause forceful ventricular contractions. The brain gets that message, but thinks it's being told that blood pressure is extremely high, 220 over 140, and does what would be entirely appropriate in the setting of a hypertensive emergency, trying to protect the organism. It reduces heart rate and causes vasodilation. That is exactly what the person with hypotension doesn't need in that setting. And if they don't adjust, they're going to get a drop in blood pressure and faint. One thing we notice is that when this is happening, patients are symptomatic. Here's a girl who had dropped out of college because she was fainting a lot. She's immediately at a 70-degree angle. You can see she's smiling. 5 minutes later, not very happy with us. And at the 7-minute point, she's fainted and lost postural tone. And the hand that's reaching out there is going to crank down our old-fashioned tilt test. So we watch for symptoms. The other thing we watch for is the slowing of the heart rate can be quite dramatic. Here's somebody that had a 12.4-second asystolic pause. That has no prognostic significance. They don't need pacemakers. And I can tell you from experience that when this occurs, the average heart rate among the technicians and physicians in the room goes way up. Catecholamines differ between people with NMH and POTS, and one of the things we've learned from the syncope patients is that their epinephrine levels go sky high when they're early into a tilt, right before they become pre-syncopal. Here are the controls with their epinephrine levels, and the fainters don't have much difference between controls with norepinephrine, and we'll see that that's different in the POTS patients. POTS is getting much more recognition. It had been described, or at least the clinical phenotype had been described as far back as after the Civil War. And it was termed irritable heart syndrome or effort syndrome, combat fatigue, neurocirculatory asthenia. It is seen much more commonly in women for reasons that are unclear. It's a little bit less common under the age of 10. And it can have an insidious onset without any clear trigger in some people, but it often appears after infection or immunization, which has led to speculation that this problem might be autoimmune in nature. And for this population, the Chiari group, it can occur after surgery or trauma, and we'll talk about why that might be later. The symptoms can be disabling, and there's been a huge increase in the recognition and probably in the incidence of POTS in the last 2 decades. The pathophysiology is quite heterogeneous. You can get forms that involve, that are called a neuropathic form, where you get a patchy denervation of the sympathetic fibers in the legs so that the vessels can't constrict adequately. There's also a central hyperadrenergic form with very high norepinephrine levels. They often have a low blood volume for reasons that are unclear, but one of the problems is their aldosterone levels don't rise when renin does. Joint hypermobility and EDS are common. Deconditioning is uncommon. If you get lightheaded and you're impaired in terms of your exercise intolerance, you often can't stay physically active, and that has consequences for worsening the POTS. And then as you'll be hearing from Dr. Maitland later in the conference, but there has been a form of POTS that's associated with mast cell activation disorder as well. Here's the catecholamine difference. Here's a woman who was tilt tested on numerous times or stood up, and here's what her norepinephrine should have been. It's somewhere in this box. You can see each time she was stood up, she got way, way up above the normal range for norepinephrine. That response could be aborted if she was put in mask trousers, which were external trousers with, that were inflated to compress the vessels from outside, or if she got a sodium loading with IV saline beforehand. So that sort of suggests a couple of ways you can treat the POTS as well. This is just a slide to remind me to tell you that some recent work from a couple of groups now, including David Kim in Oklahoma, have shown that there are autoantibodies from people with POTS that will cause vessels in the laboratory to respond as if there's some transferable factor, like an autoantibody. So the serum from patients with POTS has these antibodies that are able to drive up the beta receptors, so driving up heart rate, and also block the effect of the alpha receptor, which is what gives you the vasoconstriction. So this is new work. These are not commercially available antibodies, so you can't run out and get this tested. It's very time intensive and labor intensive, but it's helping us think about POTS in a different way. And it may be that our treatments will be very different in 10 or 15 years. I mentioned the connection with hypermobility and EDS, and Inge de Vondelay in Belgium has done some really nice studies where she has, the gray is people with hypermobile EDS, and the black on this chart is those who have, sorry, the black is the hypermobile, the gray is the classical EDS. Both groups have a fair amount of orthostatic intolerance. The hypermobile folks have other autonomic symptoms more commonly. And then the hypermobile group really differs from healthy controls a lot. So this is a big problem in EDS, we think, because the vessels are just a bit stretchier, and when you stand up, you can dump more blood into the lower half of the body. A couple of caveats about making the diagnosis of POTS from Satish Raj, who used to be at Vanderbilt, now in Calgary. Orthostatic tachycardia by itself isn't sufficient to make the diagnosis. You have to have orthostatic symptoms, usually on a chronic basis. The other thought is that you shouldn't be diagnosing POTS in the ER when somebody's acutely dehydrated or has been bleeding. Fix that problem, then see what they're like. And the other point is, I think, important, and that is that if you just focus on the heart rate problems, you're going to miss other autonomic symptoms like sweating. Hyperhidrosis can be a big problem in our patients. They have temperature regulation problems, bowel motility problems. And if you just focus on the heart rate, it makes it easy to mislabel people when they might have a different problem that's life-threatening, like anorexia nervosa. So important to make sure you know that patient well before you put a label of POTS on them. This slide is meant to sort of summarize a lot of what we understand about the pathophysiology, and it helps us organize our thoughts about treatment as well. So in these patients, you get some kind of increased pooling of blood in the limbs and a defect in their ability to vasoconstrict. They all start off with a low intravascular volume, maybe 10% lower than it should be, so that when they stand up, they get an increased sympathoadrenal response. And David Goldstein, who you'll hear from later from the NIH, thinks that if you've got more of a norepinephrine response, you can maintain your blood pressure better. And those patients will look like they have POTS, so it drives up their heart rate, but they keep their blood pressure the same, or sometimes it even goes up a bit during standing or tilt. If you have more of an epinephrine release, it causes some skeletal muscle vasculature vasodilation, and that may lead to the fainting. Keep in mind that despite what you read from a number of authorities, this can turn into this. Patients with POTS early in the tilt or standing test can develop hypotension a bit later. The good thing is, for the most part, the treatments are very similar for each disorder. And so what we do for both of them is we add vasoconstrictors to improve the amount of blood that's pooling. We give them volume expanders like extra salt and Florinef. And then we do a variety of things to try and block the heart rate elevation. Some of those are listed here. Among the vasoconstrictors are midodrine, stimulants like Ritalin and Dexedrine. The volume expanders typically are sodium, IV and orally. Florinef, birth control pills can help in young women. And then the beta blockers for reducing heart rate. But there are a number of things. I won't go into the doses here, but I'll show you a reference that includes that later if you're interested. On to some of the cases. So here is a demonstration that the orthostatic symptoms can improve after surgical decompression of Chiari. This is a paper that was published in 2005. These authors report a 42-year-old who had progressive occipital headaches, that makes sense for Chiari, nausea, vomiting, also chronic fatigue, recurrent syncope several times a week, and each episode of syncope was preceded by tachycardia and palpitations, among other symptoms, and followed by several hours of fatigue. This person also had a normal neuro exam and negative cardiac workup. This is my redrawing of the data from their paper on this person's standing test. You can see the black is the heart rate. She goes up 58 beats per minute within 5 minutes of standing and then gets pre-syncopal. So this is a picture of on the top of her Chiari malformation, and the authors report that this person's syncopal episodes and other symptoms disappeared after surgery and remained absent at the 1-year post-surgical follow-up. So this is the ideal outcome that we're looking for. These are the responses post-op, and you can see dramatically. I had a mentor, Kathy DeAngelis, who went on to be the editor of JAMA. And Kathy used to say this slide meets the intraocular test of significance because the difference hits you between the eyes. But really no POTS or pre-syncope on follow-up. Among the proposed mechanisms for syncope in Chiari, some people have thought that there's vertebrobasilar artery compression during an increase in intracranial pressure when the patient's Valsalva, or that you could get compression of some other nerve structures, either in the reticular system or the cardiorespiratory centers, or possibly in the sympathetic structures. And that could be affected by this newer concept of deformative strain or adverse tension in the spinal cord that Alf Brieg first drew attention to, and Dr. Henderson has been emphasizing for us of late. There are also papers on POTS in patients with Syringomyelia responding to medication. And here's a caution where this paper reminded people not everything needs a neurosurgical correction. So they had a 33-year-old who had headaches with coughing and sneezing, some difficulty swallowing, unsteady gait, Chiari malformation, and a syrinx were identified. Those were fixed surgically and the headache resolved. And she did pretty well for about 8 years when she developed palpitations, shortness of breath, nausea, lightheadedness, a tendency to fall, even some anxiety, usually when she was standing. And because her exam was normal, other than the tachycardia, they thought this must be psychogenic at first. The MRI looked okay. The syrinx had not returned. And this might be a bit hard to see, but they did a tilt test on her, and this is her heart rate going up, confirming the POTS, and then at about the 18-minute point, blood pressure plummets. So they treated her with Florinef and atenolol, and the post-treatment tilt test was normal. So this was somebody who didn't need re-exploration. She needed the appropriate treatment of her autonomic problems. And I mentioned that we've had some patients who didn't have clear orthostatic intolerance beforehand, but seemed to have this after Chiari decompression. One of the reasons for that might be the physiologic response to complete recumbent posture. This is a slide showing what happens if you take NASA astronauts in the old days, I think before ethics committees, Roger, I gotta think, who would lay in bed for 220 straight days not getting up to go to the bathroom? But this was to replicate the post-space flight orthostatic intolerance that the astronauts would get. The key finding for our purposes is that within the first 2 weeks of complete bed rest, these people were losing 15% of their plasma volume. And we know that if you lost that on a single day, you'd be in shock. So if it develops gradually over 2 weeks, I think most of us can appreciate that that could occur if you got a really bad flu, really bad mono, or you had a difficult time recuperating from your Chiari surgery or whatever other surgery you had. So post-operative orthostatic intolerance might be related to this in some cases. So here's a girl that was the child of one of my faculty colleagues who was very energetic and active until she was 14. She got some bitemporal headaches and fatigue that fluctuated. 6 months in, she had an increased headache frequency and had a bit of numbness down the left arm and around her mouth, and often felt a need to lie down. And people she had her first syncopal episode 9 months after the onset. And by this point, she had a continuous headache and couldn't attend school. So her exam showed nystagmus. She had a positive Romberg. The MRI fit with Chiari. And after the decompression surgery, she had an initial improvement in the headache that lasted about 3 weeks. And then a different headache came on. It was a dull bitemporal headache with some vertigo, some room spinning. The ENT people saw her, did their vestibular tests, which were normal, so they thought maybe the vertigo was due to migraines. My pediatric neurology colleagues thought so as well, but she didn't respond to any of the migraine drugs that they threw at her, and they even tried her on the modified ketogenic diet without effect. So the parents came to me wondering if there were other things going on. And what struck me was that her headaches were occurring on most days, but they occurred later, after she'd been upright for a while, starting in the mid-morning and lasting the rest of the day. The headaches were worse in a hot environment. She had some visual blackouts several times a day and would only endorse lightheadedness occasionally after a hot bath. Didn't feel sharp mentally and was having to reread things over and over and would forget them soon afterwards. And this is a very good student. So we decided to do a standing test on her. Her exam showed a bit of slowed pace in her verbal responses. Her nystagmus had improved after the surgery, so that had worked. She had a bit of neck muscle tightness around the scar. And her standing test was really interesting. She had a pretty healthy, around 60 beat per minute heart rate. She went up 38 beats per minute, so she didn't quite meet the POTS criteria. Blood pressure initially went up a bit, and then it started drifting down. And at about the 9-minute point, she got really hot. And when we hear patients are getting really hot, we need to sit them down because they're about to faint. She was pre-syncopal, had worse headache and nausea, had to sit down, and her blood pressure dropped from the peak from 101/60 pre-test to 88/40. But this was when she was already lying down again. If we'd been able to keep her up without her injuring herself, we probably would have captured a lower blood pressure. So we thought her pattern fit with neurally mediated hypotension. We started her on salt tablets. She immediately felt fewer headaches. We added Florinef to improve salt retention in the bloodstream. We sent her to a PT for her muscle tightness in the neck. And then when we added midodrine as a vasoconstrictor, she really did much better. And that summer was able to swim for her summer swim team, went to college, and she's now a medical student doing well. So that is a case where soon after surgery, you get these symptoms that could be from anything in the nervous system. It might have led somebody to re-explore things, wondering if there was a problem. This kind of treatment and attention to this can avoid that kind of surgical misadventure. And then lastly, I want to talk about a series that we've put together of patients who had met criteria for chronic fatigue syndrome and POTS, and also had anxiety. And all of these things improved after the recognition and decompression of cervical disc disease. So the first of these patients was well until she was 12. After a GI virus looked like the standard kind of gastroenteritis, she got fatigue, lightheaded, tachycardic, and some problems with thinking and concentrating. By 15, she could only do part-time schooling, and later that year, she had to stop attending school full-time in grade 10. She had minimal responses to the medicines we use for these problems. I kept examining her, wondering why were we getting nowhere with this girl. At age 19, she finally had an intermittently positive Hoffman sign, which led me to do her MRI. The clue that should have led to us doing that earlier was the family history was really unusual. The mother had had 2 surgeries for congenital cervical stenosis, one at 34, the other at 43 years. And she'd had thoracic outlet surgery twice. So there was something clearly wrong in this family in the neck. This is this girl's standing test. We only went 5 minutes because it was so dramatic. She had a 64 beat increase up to 150. Most of us don't get to 150 when we're on the treadmill for 20 minutes. So this was a dramatic amount of POTS. And here's her MRI. And those of you who can make this out can see that there's very little spinal fluid on either side of the cord. So she had a canal diameter of about 8 millimeters. Anything less than 13 is stenosis. So she had a congenitally stenotic cervical spine. But she'd had that all her life. Why did she start getting sick later? Well, she had a disc bulge at 6'7" that was compressing the cord, and her canal diameter at that point was just 6 millimeters. We sent her to a spine surgeon who said, I don't know anything about this fatigue and tachycardia stuff, but you need that disc fixed, or else you're going to get in trouble if you get into a whiplash injury. So he did a disc replacement. Notice also that she had a somewhat abnormal clivoaxial angle here, and we wondered how much that might be playing a role, but we elected to do the least invasive surgery first. So she gets this disc replacement. Within 2 months, she was exercising more, taking a job as a dog walker. She actually noticed cognitive improvement in hospital. She was clicking away on her computer, emailing friends. 6 months later, a little bit to our chagrin, she took a job as a horse wrangler at a camp in Colorado where she was saddling horses, taking people out on rides, then fixing the horses later, full activity. And that fall, she began her full-time college career. She just graduated in December. During college, she could work 12 hours retail. She did photograph shoots on the weekend, and she has full function. But one of the lessons that we learn in treating people with chronic illness is they try to give their doctors heart attacks afterwards, and she's now doing rock climbing as her favorite exercise, but really a complete improvement. This is her pre- and post-surgical circulatory responses. POTS has resolved. The free-floating anxiety she had got better, too. Here's her mother's MRI showing that the apple didn't fall far from the tree in terms of the spinal abnormalities. And here's a second patient that we were encouraged to look into who had hyperreflexia, positive Hoffman signs, and 6 years of what was thought to be psychosomatic stuff by her neurologist and chronic fatigue syndrome. But she had a compression at 5'6" and 6'7", and those of you who are up closer can see that this cord is sort of deviating away from these disc bulges. Her canal diameter was 7 millimeters at the smallest diameter, and she had myelomalacia. So she underwent the surgery and had an almost identical improvement. We did a third patient. Again, there's her post-op circulatory responses. And all 3 of the patients that we've had with similar findings, here's what their heart rate increment during tilt came down to. It normalized in all 3. Their SF-36 physical function scores, a quality of life measure, went up to about 30, which is the top score you can have. And their Karnofsky score, which is another quality of life measure, improved dramatically as well. So these were examples of patients who had really been miscategorized, even by very good people, because we hadn't been looking for other kinds of cord compression. If you want to look at other references on this, there are a couple of really good review papers. Satish Raj has one on POTS in circulation a couple of years ago. Blair Grubb has a nice review on neurocardiogenic or neurally mediated syncope in the New England Journal. Julian Stewart from Valhalla, New York, has some very nice papers on orthostatic intolerance in pediatrics. There are a couple of diagnostic and review papers by heart rhythm societies and cardiologists. I think the American Heart Association just came out with a new one on syncope. And if you want to learn more about the dosing, I did a webinar about 6 or 7 years ago for the Chronic Fatigue Syndrome Association. And if you look on YouTube for this webinar under Managing Orthostatic Intolerance, you have to search Dr. Peter Rowe. If you leave out the doctor part on the YouTube search, you get to the guy who was the filmmaker of the old film, The Little Shop of Horrors. And some of my colleagues think that's hilarious because that's what they call my clinic. Dysautonomia International is another good patient advocacy group that has some very nice talks on orthostatic intolerance on their website. And I'll just conclude with these comments. Although the association with syncope and Chiari is well known, non-syncopal orthostatic intolerance can be an early manifestation of Chiari and cervical stenosis, sometimes with a protracted prodrome before the classic neurologic symptoms and signs emerge. Decompression of either problem is associated with marked functional improvement, but it's not just self-report. There are objective cardiovascular indices that accompany those improvements. I ask people to be alert to orthostatic headaches as a feature of orthostatic intolerance rather than a problem that might be thought to be stemming from an inappropriate surgical repair. And one of the shared risk factors that you'll hear about more from Dr. Francomano and her colleagues for both Chiari malformation and orthostatic intolerance could include connective tissue laxity, as joint hypermobility and Ehlers-Danlos syndrome are more common in both. Just a thanks to the Sunshine Natural Wellbeing Foundation that has endowed the professorship that supports me. I had a volunteer research coordinator for many years, Colleen Marden. We've had great summer students working with us, helping with data entry and research, and a lot of our work has been funded by private philanthropy. So I'll stop there and see if people have questions. Thank you.
Thanks very much, Peter. I don't know if we've gotten any questions coming up from the computer guys outside, but I had one in particular. It's often struck me that we see a bit of this orthostatic intolerance, and so, of course, do the cardiologists, and they invariably start everybody on beta blockers, and it seems to me that most people get worse. And you did mention Avibactrin, and it's easier to say Corlanor, but this is a drug that is newly available, and there is a lot of discussion on the websites in that about its use particularly in patients with orthostatic intolerance. What's your experience with that? Because I've only treated one patient and don't really have too much to say about it.
So ivabradine or Corlanor blocks a channel in the sinoatrial node that's called the funny channel. I think a couple of the physiologists were having drinks when they named it that. But when it's blocked, it slows down heart rate without affecting blood pressure. And it's been available in other countries for a number of years. There are two series that I know of, one in England and one in Israel, showing that it's effective in people with POTS. It's safe. About half to two-thirds of the people in those series seem to improve. We've used it. We don't see quite that same rate of improvement, but occasionally it can be quite dramatic. So one example was one of the girls who's helped us on our research studies used to have a problem where her resting heart rate was 110 despite everything we were treating her with. And if she tried to exercise, she'd go up to 180 within 2 minutes. And she'd trigger a massive migraine. So anytime she exercised, she was killing herself with symptoms. So she just couldn't do it. We put her on a tiny dose of ivabradine, 2.5 milligrams once a day, then up to twice a day, eventually up to 10 milligrams twice a day. Each time we increased the dose, her resting heart rate came down so that on 10 milligrams, she was at a resting heart rate about 75, which is pretty good. And with exercise, she would only go up to about a heart rate of 130 without triggering a migraine. And she was able to lose some of the weight that she'd gained from her inactivity. And the best part of that story was last fall. She's now working as an OT out in Arizona. She sent me a slide of some place in Sedona that she'd hiked to. It was 5 miles out and 5 miles back in one day. And when I presented that case at the CFS conference, I preceded it with a slide that said, "We don't need no stinking p-values here."
Very good. All right, thank you very much. I'm sure there might be some more questions. There certainly will be some follow-up in the next days with, on Sunday, the focus on EDS will be important, and there are some really good talks with that, so I hope you'll stay tuned for that.